very delighted to be chairing this meeting today on this very important and, from a technical point of view and a psychological point of view, extremely interesting subject. So let's start the proceedings now. We've got two towering authorities to speak to us today, Brendan Delaney and Willie Hamilton. And I will start with Brendan. I know Brendan very well at the University of Birmingham here, which he left to go to another university, I can't think what. And but there he has flourished and is one of this country's foremost people. He's worked on this area of diagnosis for a very, very long time, and is very extremely expert on the psychology and medicine of the subject. And it's a great pleasure and privilege to have you here, Brendan, and lovely to see you again. Over to you.
Thank you, Richard. I think you can see my slides okay. Yes, I'm at Imperial, and I'm actually based at a part of Imperial called IX, which is a physical cross-faculty place on the White City campus, where we bring together people who are interested in development of AI, mainly from maths and computing, with people like myself who are interested in applications with industrial partners. So it's a very interesting place to be. As Richard said, decision support and diagnosis has been quite a long-standing interest of mine. And here is a paper from my colleagues in Birmingham back in 1999 in the BMJ. And I think the little caption that little picture that the magazine put up was quite prescient, actually. So let's think about what artificial intelligence is. It's a term which is hugely bandied around at the moment. But the Information Commissioner's Office has defined it thus as an umbrella term, range of algorithm-based technologies solve complex tasks, carrying out functions previously required human thinking. So the idea about it being a group term, about algorithms, and about taking over tasks from humans, I think is the key here. And it's that taking over tasks which is the key bit. But when you say to the public artificial intelligence, people will think of 2001: A Space Odyssey and HAL the Rogue Computer. So I think we have quite a challenge in making clear what's going on. I won't play the HAL clip. However, past couple of years, particularly, there's been a huge boost to AI with machine learning and generative AI. What generative AI is shown here. It's doing some translation work, and I'll attempt to have a brief explanation of this. So first of all, any kind of data set is broken up into tokens. Now, these could be words, they could be concepts, they could be pieces of data. Almost anything can be treated this way. So you have a token, piece of information. And this data is analyzed using a neural network, which is a set of layers with nodes within that, where the relationships between the data are represented as vector relationships, i.e. directional relationships between the nodes and layers. So you have a very complex way of representing the data set. And you can focus attention on memory and things, so what's most recent, what do I need to know given this, by putting a recurrent loop around those. So that's known as a recurrent neural network. So if you have a chain of recurrent neural networks, you can create a predictive model. Then came along the convolutional neural network, which is faster, runs parallel processing, and has been used quite widely in image analysis. But the big innovation was brought about by Google, actually, which is to take attention scores, to put in additional weights that looked at the context of larger passages, so other paragraphs in a piece of text, other sentences, not just the immediate sentence. And what these weights are is they keep track of what's important within a piece of data. And this is called the transformer. So parallel processing, attention scores and weights. And transformers are incredibly powerful at summarizing knowledge from large and complex pieces of data. And from these, we have large language models, which have been trained on very large amounts of text data, billions of pieces of data, largely from scraping stuff from the internet. So it seems hardly a day goes by without a further advance, a later version, another model. We have GPT 4.0 or 4.0, which just came out this week. And there's a whole branch of innovation in computer science around engineering the prompts and instructions that you would give to retrieve information from this large language model with things such as chain of thought engineering. So you can tell, for example, if anyone, I'm sure many people here have played with ChatGPT, you can get it to do things if you're very precise about asking it to do things. I've been playing around recently with taking transcripts of meetings and saying, given this agenda, please summarize the minutes, and here's the transcript. And it's quite good at that kind of thing, but you do have to watch it a bit. More of that in a minute. And you can take these large language models and you can fine tune them by adding in additional information. Say, given this document, what would, can you now summarize it? But there are also domain-specific language models, and there are a few in medicine, and you can take your own large language model, or your own model, and train it. And I'll come about that in a minute. So, however, there are some challenges. Sorry, could you mute yourself, please? That's very interrupting. There are some particular challenges around large language models, in that if you put biased data in, you always get potential for bias coming out of an algorithm. And these are very complicated algorithms, so it's very difficult to see where bias has come from. So it's likely the potential for biased information will be greater in coming out in the recommendations. They lack logical explainability, because even if you ask them to explain the recommendation, they will generate that by this complex pattern matching. They don't have knowledge themselves. They're a way of representing links of knowledge, but they don't have formal logic that you would understand from a computing perspective. They can therefore hallucinate, although they have got a lot better, as instructions have been fed into the system to prevent some of this. And you can ask it, for example, please make sure the references you provide are real. However, they do come under software as a medical device, and almost certainly will require NIHR approval where a medical device is being used. And they're also known as software of unknown provenance, because we don't know what's gone in to making them. And a new version can be created, an update that may change all the way the algorithms are working. And these things therefore need to be thought about and updated as part of a learning system. Now, we've been working with a simple approach to a transform model called BERT, which was one of the original. And it was open sourced in 2018. You can think of it as a small language model, if you like, but you can take it and you can use it to train on data. And we did this using an embedded case control design in the Northwest London GP data. So it's about 2.5 million patients worth of data from Northwest London practices. And we split out 30% of the data at the beginning to do a validation. And we were interested in trying to build a transformer-based model for lung cancer prediction in primary care, looking at the sequences of coded information in the GP record prior to a diagnosis of lung cancer, because we actually have quite good data quality for capturing cancer these days in these GP databases. And we wanted to try and improve the performance on the Q-cancer lung model, which is the existing standard. So what you can do here is you can take events which appear as a sequence in the GP record. It's not text, it's codes, but it could be a smoking status, an intervention like a chest X-ray, a symptom recording, a diagnostic episode, anything that's coded. And there are more than 23,000 codes in the WYSIC dataset in Northwest London. And you can't put 23,000 codes into a model and expect it to do something sensible with those. So myself and colleagues, we went through a very laborious grouping up of codes in a systematic way. So using the SNOMED/READ hierarchy to group up and make groups. So, I mean, we ended up with 450 code groups. So with 450 elements, you've got a chance of running a BERT model through doing that. So the way this works is you've got your data set underneath, you've got your layers, you've got the representations between the nodes, and the top layer is your modeled representation using transformers and weightings of the care pathways of patients with and without lung cancer. We call these embeddings. So think of them as a sort of summary, or a large language model summary of what that data looks like. And then these embeddings can be put into a logistic regression classifier. You can put any kind of mathematical top level. You could put a Bayesian network, you could all sorts of things. But that top level gives you your answer. So we do a logistic regression classifier on our embedding representations to try and discriminate between patients who were diagnosed with lung cancer and those who weren't, given the pathways leading up to things. Now, as ever, there is potential for bias. You need to explore quite carefully what's going on here. So we took an estimate of the area under the ROC curve and sequentially took out a number of months just before the index diagnosis. Because of delays in coding and coding of things that may be highly representative of cancer, Willie will know this because he and Julie have done very similar things with their models. You take out things that are just about diagnosis because they may have been influenced by knowing the patient had a diagnosis, or it might actually be something on the care pathway like 2-week wait referral. And obviously those things are quite predictive, but not representative of a patient coming in where you might want to think about lung cancer. So if you do that, you can see that over the time the ROC curve area increases a bit, it goes up a little bit, and very sharply in the last month. So we took out that last month of data. We then end up with quite good separation between lung cancer and non-lung cancer populations on the model. And and then we have two areas under the ROC curve here. The one on the left is our deep learning model with logistic regression classifier. The one on the right is just the logistic regression classifier. So without that pathway embeddings on it, it's actually quite good anyway. And adding in the deep learning model adds about an extra 4% to that. So I think a lot of the value of this is in that careful curation of codes. So how might we be using this? So let's think a little bit about diagnosis in general practice. I am a GP. I was duty doctor in my practice yesterday, so I still have my feet on the ground. Diagnosis is a core competence for primary care, because if you don't get diagnosed promptly in primary care, you will suffer throughout, as a patient, your further contacts by being late diagnosed or misdiagnosed. And there are certain time critical diagnoses, mainly in cancer, infection, and heart disease, not stroke as well, which are really critical time-wise. So, as Richard mentioned, they're a common cause of malpractice claims, and it's the kind of things that GPs remember. I didn't diagnose that patient. I really feel bad about that. It's important. So, why is it challenging? And this is based on work done with my colleague Olga Kostopoulos. It's based on first impressions, and you've shown that we make decisions as GPs in just the same way as anyone else makes any decisions about anything. So we use the human mind, and that is driven by unconscious thought. So the instant a patient steps into the room and starts talking, our unconscious thought is generating a potential diagnosis with all the biases that we know exist in unconscious thought. And unfortunately, subconsciously, the human mind seeks to support evidence for those initial beliefs by specifically asking questions focused around that and ignoring things that you haven't thought of as a potential diagnosis right at the beginning. And even if you do ask the question, you get an answer, the answer is distorted to help to support that what you're thinking about, because we like to make consistent decisions, and our minds are subconscious, consistent, biased decision makers. It can work good sometimes if you get the right thing in the first head, but often it leaves people wrongly. So what we've done a lot of work on is thinking about how we might change that. Now, where we are currently, I'm afraid still, in the vast majority of practices is we have a little alert that comes in the bottom, says, here's a risk score running in the background, an algorithm, which says patient might have cancer with a risk of 4.78%. And it's not what you're thinking about. You're probably talking about something else, like pre-diabetes or something. And this is based on information in the patient record in the past. So a lot of it's going to be driven by comorbidity and age and sex, smoking history, that kind of thing. You can click on this and it will give you some additional questions to ask, but it's a complete diversion to the task in hand of the consultation, which is busy enough anyway, which I think leads into the general problem that patients don't walk in with, I might have cancer written on their foreheads. They come in with a problem, and often it's a very vague problem of which the cancer is way down the list. It could be fatigue, general malaise, or a cough. That's a little bit of weight loss. Now, if you're interested in this, you might think that every patient that comes in and says, I may have lost a bit of weight, you're thinking, oh, they might have cancer. I know Willie and I probably do that, but the majority of GPs, that's not the first thing on their mind. In any case, these kind of alerts have really got quite ridiculous, with a number of things operating for prescribing, for this, for screening, for that, the other. I mean, it's an absolute forest of alerts at the moment. And these things are not informed by any psychological theory, so it's not a stable solution. The solution here is probably Larry Weed, who was the beginner or the initiator of the problem-orientated medical record back in the 1960s, with the article Medical Records That Guide and Teach. And this has been ignored, particularly by EMIS, where GPs put in problem. What on earth is a problem? Is it the presenting problem, or is it the diagnosis you've made? Unless you separate those out, you can't think about that. So we did some work over a number of years around making a prototype decision support window to support diagnosis, which listed the differential diagnosis that was problem orientated and built the relationships between symptoms and signs. And we showed with simulations and with actors that you could improve accuracy with an odds ratio of 1.4 and improve management and diagnostic certainty. However, taking this out into practices and trying to plug it into the existing EHR systems proved not to be practical. So I'm very pleased to say, and I have to say this is currently press embargoed after a long period of time, that we've got a new project funded by NIHR, the I4I program, and the Office of Life Sciences Cancer Early Detection Call, which brings together my colleagues at Imperial, with the NHS in Sussex, with QMUL, Garth Funston and Fiona Walters Group, and a US startup called Soap Health, which is led by Stephen Charlap. Now, the idea behind this is to take all the information gathering from patients and the collection of an unbiased history out of the realm of the general practitioner, so that a virtual doctor, shown on the next slide, takes a history from patients with the ability to speak and to understand, or to just drop into speak mode and click. You can choose how the interaction works, but patients can, if they wish, just speak. To use a combination of a large language model and branching logic to collect a full history with all the nuances around that, any additional things, to ask patients such things as, what's your priority for the consultation? What are your expectations? A gold standard medical history, without all that bias about biasing it on which questions are asked because of developing hypotheses. Then to say, given that information and given what we also know about the patient, what are the potential diagnoses, to use a knowledge model to do that, and then subsequently to present that in a way that supports diagnosis process from the GP in doing that. So the project has three parts, which is about medical device validation of the history taking component, building a much stronger regulatable foundation for the differential diagnosis generation, including models like I've described with the BERT model that we built, and then to provide an integrated decision support system which then plugs into the EHR system. This is Jeannie, I'll display that. I mean, it's also.
Hi, I'm Jeannie. I'm the virtual assistant created by Soap Health to revolutionize healthcare through the power of artificial intelligence. As the perfect medical interviewer, I conduct automated patient intakes before appointments. My conversational interface guides patients through a comprehensive interview covering their health history, medications, family history, lifestyle factors, and more. This not only saves physicians time, but also ensures no critical information is missed. I can capture more complete patient data than traditional paper forms. My advanced natural language processing skills allow me to have fluid, natural dialogues with patients and understand complex health information. After the automated interview, Soap Health's Risk View feature analyzes the patient data I've gathered to identify any potential health risks or red flags. This gives doctors actionable insights to improve preventive screening and early detection of diseases. Finally, I generate a smart soap note that pre-populates all the essential documentation for the patient visit, integrating directly into the doctor's electronic health record system. This automates up to 90% of the documentation process, saving physicians 2 hours per day that can be better spent on direct patient care.
Okay.
Hi.
Whoops. So, last slide. What is the future? I think it's an incredibly exciting time, actually, as a researcher in this area, and actually a time where we can start to do something really useful. There are a lot of things that I've listed about how AI may impact practices, but I'd like to look on the right-hand side there, which is, I think, quite local to Richard and colleagues. It's a series of locks to climb a hill on the Kennet Naval Navigation. This was built in the mid-19th century as an incredibly exhaustive and difficult task to get the canal boats up this hill. 40 years later, it was superseded by the coming of the railways. I think we're at a railway moment in the application of AI in healthcare. Thank you. Look forward to the discussion.
Gosh, Brendan, that was such an interesting talk, and if I may say, so expertly delivered. So thank you so much for that. And for me, it was nostalgic. My thesis, funnily enough, all those years ago, was about use of computers to take medical histories. But you would laugh at that now with that sophisticated AI based application. Brendan, thanks so much. We're not going to have questions now. We're going to have all the four speakers, and then we'll have a discussion among us all. So our next speaker is Professor of Primary Care Diagnostics, so right on the mark at Exeter University. He's my friend and colleague, Professor Willie Hamilton.
Starting off muted. Can you now hear me, Richard? Give me a wave. Good.
Yep.
Thank you very much. It's always tricky following Brendan because he's got a brain the size of a planet, and I'll do my very best to keep up with you, Brendan, but it's a difficult task. I think we start off with a tiny reality check about what goes on in general practice. Diagnosis is important, but it's actually a minority sport in general practice. We do an awful lot more in terms of treatment, follow-up, support, management of existing conditions, and maybe that's part of the problem why errors do occur, because the idea that the pure case that Brendan alluded to of the individual coming in saying, I've got a cough or I've got fatigue, is relatively rare. So we have to get it right, of course, when it comes, but it's not quite as much our bread and butter as many people think, while remaining terribly important. I'm going to talk mostly about cancer because it's my main area of work. Brendan has done a couple of cancer examples, so forgive me. There are obviously equally important things to cancer, but cancer's been my lifetime, so you're stuck with me. And early cancer diagnosis has seemed to be important for a long time. That 1 in 6 book was published in 1955. It's the oldest one I could find about cancer diagnostics. But the number of publications now has just gone up and up and up. Key thing, I think, is how much does delay in diagnosis of symptomatic cancer matter? Now, I don't want you to read this entire slide. That would take up my full 20 minutes and you'd be brain dead at the end of it. But what this slide does is allocate the survival disadvantage to all the cancers listed on the left column, depending on how long the delay is. I'm going to simplify the entire slide with my 4th bullet point on the left. A very broad average across all the cancers, across all the ages, is that every week in delay of a symptomatic cancer roughly approximates to 1% worse survival. You can see from the chart there's greens and there's reds and there's yellows, so that figure doesn't work for every cancer and every age. But the key thing is just think of 1%, or 4% in a month if you like. Cancer diagnosis matters and cancer delay matters to the media, to patients, and to doctors. Richard has alluded to this being the largest cause of claims to our defence unions. And it's also, it's in the media the whole time. You can't read a newspaper without one of these stories appearing. And if you think that's just the only one, look at this lot. That took me about an hour to assemble that slide. There were so many stories out there, including this one on the bottom. The bottom line, your fridge kill you. I have no idea what that was about, but the fridges were causing cancer in some shape or form. It's almost certainly the fridge in my university department is the guilty one. How do we diagnose cancer in primary care? Our job is primarily symptomatic diagnosis. I want you just to have a thought experiment. I can't get you to put your hands up, but who's had a headache? I'll put my hand up, actually. I had a headache, but I took my paracetamol. I'm feeling dandy now. Fatigue, everybody's fatigued, even if they don't look like Chatterton lying down his chaise long. Cough is almost ubiquitous. Now, any one of those could be cancer. I can quote you a PPV, a risk of cancer with each of these, but our difficulty is, as GPs, is essentially any symptom can be cancer. And so we have to sift out which patient with which symptom has a high enough risk of cancer to warrant investigation. And here's some numbers on it. If you look at a year, for 1,000 UK patients, something between 14 and 90% of rectal bleeding in any one year. But a large amount of that goes unreported. But 129 of the 1,000, so 13% of the 1,000 randomly selected people over the age of 40, have a cancer symptom in their GP records with a PPV, a risk of cancer of greater than 1%. 43 people have a 2-week wait appointment or an urgent suspected cancer appointment, and of those 43, 6 patients have cancer, with currently just under 20% of those patients presenting as an emergency. So while I'm saying it's a diagnosis of a minority sport in general practice, something like 80% of cancers do present through general practice, so we have to be able to pick this up. So it's a classic safety issue. Of course, you know about the NICE guidance. It's been now out since 2015. I was the clinical lead on it, and I had lovely nut brown hair before I started doing that, and I can promise you my hair is no longer nut brown, no lovely at the end of it. But I think the crucial point here is my first bullet point. There is not one feature in the 210 recommendations in the NICE guidance in which cancer is more likely than not cancer. And I think this was Brendan's point earlier, which he made well, that we have to try and get away from the single disease focus. Even a breast lump, it's your chance, depending on age and how the breast lump feels, is more likely not to be cancer than cancer. So the crucial thing here is that, although I focus on cancer and Brendan has to an extent focused on cancer, the beauty of general practice is that we are able to think of other things at the same time. So actually having symptomatic patients with possible cancer coming through the general practitioner allows we GPs to sift out which ones are less likely to be cancer than they are to be cancer. And GPs are adaptable. This slide, I'm not going to go through it in great length, but look at the bottom left of the 6 graphs. This shows how quickly cancer was diagnosed after a GP attendance. And the downward dotted line about 3/4 of the way along the graph is when NICE was introduced in 2015. And after 2015, there was a diminution in the time to diagnosis for several cancers. And these were the cancers where new symptoms had been brought in to the NICE guidance. So we GPs are adaptable. We do think. And indeed, many of these graphs you can see are actually falling before the NICE guidance come in. So heaven forbid you might be reading my research papers, or you might have been going to other seminars like this one and actually learning from this about the symptomatology of cancer and making good referrals as a result of it. I'm going to skip this because time is tight. Right. I think this is an important one. The question I've put on the top of the slide is, what percentage of patients with a high-risk feature of cancer have a low-risk feature of cancer before? And it's tiny. The number that have a low-risk feature, so in other words, the patients with, shall we say, breast lump, with a risk roughly around 6 to 10%, depending on age, present with a low-risk feature of cancer earlier, shall we say breast pain, or it's around the nipple or nipple retraction, is tiny. So the idea that patients with cancer start off with a low-risk feature and it slowly progresses to become a high-risk feature, and then the penny drops and then cancer is diagnosed, is not supported by the evidence. Patients seem to come either with a low-risk feature or with a high-risk feature, but not progress from one to the other. Another thing that's important is patients want to be tested for cancer. And this is a piece of research that we did where I wrote vignettes of patients with symptoms of possible cancer. So the lung patients either had cough, or sometimes had hemoptysis, or sometimes a loss of weight, or a mixture of them, representing risks of 1%, 2%, 5%, or 10% of cancer. And I described the cancer, and I described what would happen if you were investigated for cancer. And we said, would you like to be tested for cancer now? With this vignette, we captured the patients in the GP's waiting rooms while they were waiting for anything. And what we discovered was that patients desperately wanted to be investigated for cancer, almost irrespective of the risk of cancer. So 92% of patients who I had written a lung cancer vignette were saying, give me a chest X-ray. And the pancreatic people were saying, give me a CT abdomen. What was interesting was the colorectal people did show a ladder of risk. So those with a lower risk, and the risk is missing in these 4 red bars. The first one was 1%. So only a mere 80% of patients presented with a 1% risk of colorectal cancer wanted a colonoscopy, whereas nearly 90% presented with a 10% risk of colorectal cancer wanted a colonoscopy. I think that simply reflected the fact that I described the effective preparation for colonoscopy rather graphically. And the patients were terrified of the preparation for the colonoscopy rather than wanting cancer investigation. But that does leave us with a problem. We know patients want investigation almost irrespective of the risk. And we know the NHS cannot offer that investigation simply because of resource implications. So we have to recognize this gap. And this gap is where the patient safety comes into a lot of the time. The patient with the low risk but not no risk symptom who is uninvestigated. Let's briefly come back into the GP surgery and discuss 3 groups of patients who suffer as a result of this. The first group is the invisible patient. And this is the patient who has chosen, I use the word chosen in inverted commas, the wrong symptom for their cancer. And approximately 30% of cancers present initially with a non-specific symptom, like weight loss, like abdominal pain, like fatigue, like raised platelets. I know raised platelets isn't a symptom, but it's very non-specific. And it's low risk, but not zero risk. And there's often no primary care test to do. A patient in their 50s with abdominal pain that's unexplained, there's no simple test you can do in general practice to try and tease out whether this may be cancer or not. Or you may have tested them, the treehouse test is normal. You may have done a fecal immunochemical test. You may have done a CA125 and they're normal. So these invisible patients with low-risk symptoms, usually abdominal, often find that their cancer diagnosis is delayed. Now, there's another branch of invisible patients, and that's the ping pong patient. And again, they've chosen, inverted commas, the wrong symptom for the cancer. And again, it's non-specific. And these poor patients, when the GP has identified the possibility of cancer, bounce from specialist to specialist, sending to the upper GI individual who does an endoscopy and it's not esophagogastric cancer, comes back to you, goes to the lower GI individual, has a colonoscopy, it's not that, and eventually then the pancreas is identified. These have been solved quite a bit by the rapid diagnostic centres around the country, but there's not enough of them, and there's not enough patients being referred to them to yet be making major inroads into the ping pong patient. But that's a crucial patient safety one, is to try and avoid this sequence of primary care, secondary care, bouncing around with patients. This one is a slightly scary one. This is the bullseye patient, and this is the patient who has the right symptom for the cancer. And NIHR's NG12 says, do something. This is what happens when you look at GP records with symptoms that would qualify for NG12. Just over 20% of patients who have significant enough anemia to qualify for an NG12 referral actually receive a referral. Breast lump, I was staggered at this. Only 2/3 of women with a breast lump appear to get urgent suspected cancer or a direct surgical referral for that. Some may disappear off to the private sector, but not that many. And the same goes for dysphagia and everything else. Now, this looks terrible. You're like, what's going on? Because every woman in the world who identifies a breast lump thinks it's cancer. So why are only 2/3 of these women only being referred? What is going on? Well, oops, I nearly said a word there. Let's look at this. If you then look at the patients with, let's take the third one down, with dysphagia, who have been referred, their cancer strike rate is considerably higher than the strike rate of the dysphagic patients who are not referred. So what you're seeing from this slide is that GPs are doing their job relatively well in identifying within a single symptom which ones actually may be malignant against which ones may not be malignant. I would then argue that, yes, GPs are doing jolly well in sifting this out, but they've not turned the dial enough so that those figures on the left are down smaller and smaller. For every patient on the left who has cancer, that averages out at just over 3%. Who have a delayed diagnosis with a 1% worse survival per year are being disenfranchised. So we GPs are doing well, but we need to do just a wee bit better in our non-selection of patients when NG12 says we should be referring. The other issue that's a real safety issue for us here is primary care testing for cancer. Chest X-rays miss about lung cancer in 5. And of that 1 in 5, about half of them are hidden behind some useful structure like the heart and simply can't be seen. And the other half are missed because the radiologist, in retrospect, missed it. AI, Brendan, you didn't talk about image recognition, but AI recognition, image recognition may reduce that second law. FIT, slightly better. It is somewhere between 10% and 16% of patients with a colorectal cancer have a negative FIT using the currently accepted figure of 10 micrograms per gram of feces. And CA125 for ovarian cancer has a 23% miss rate. These sound bad, but actually they're better than not investigating at all. So it is important to recognize that even though tests are false negatives, it is still worth using them, but keeping your mind open if the test transpires to be negative. This is my only slide on safety netting, and I've left a space. And I've left a space because everybody defines safety netting differently. So you're going to have to hear my definition. My definition is the clinician in partnership with the patient, and that's the crucial bit, in partnership with the patient, agree some form of reassessment later. Now, the reassessment may be because symptoms have got worse or because symptoms have not gone or whatever, but the crucial thing is you have agreed with the patient that the diagnostic experience, the diagnostic pathway is not closed at this point. Now, as I said, there's 101 other definitions, but the crucial thing is patient agreement within that. Right. The last little bit of slide is clinical decision support. Now, Brendan talked about terribly sophisticated clinical decision support. I'm talking about somewhat less sophisticated clinical decision support. We know the risks for any one of these cancers on the slide with particular symptoms. And we've put them on mouse maps. I've got one actually hiding here. I'd wave it in front of you one, but that's useless. Mouse maps are so last century. But big red or X for that one. But we put them in EPIT systems so that the prompt, Brendan described the older form where you can actually lift the prompt up deliberately. What we've done is now get a prompt to pop up. If the symptoms coded features in the GP's record within the last year add up to a possibility of cancer of 2% or greater. So that will pop up in the corner. And my little cartoon in the middle, of course, describes many GPs' responses to pop-ups, that they're not universally popular. So we have to make sure that they are very targeted, which is why we chose a respectively high chance of cancer. Yeah, and that's often the end result, but that's we have to live with that. So what we have done is we essentially completed a trial of putting these pop-ups into 477 UK practices, or strictly in half of 477 UK practices for 2 years, and we are assessing what happens in terms of cancer stage diagnosis. So we are hoping to see the presence of these pop-ups in such a big trial to shift diagnosis earlier so that stage diagnosis is improved. We will have the results next year, so you might have to invite me back for Patient Safety Day next year. Yeah, Brendan, I wrote this slide before you talked. And look, I wrote, it's exactly what I wrote in the slide. That's all there is on the slide. And my is because of the idea of the robot will see you now. There is something about a human being that I think matters in general practice. And I love the way your video had a young curvy woman instead of a ghastly robot on the left. And I was trying to humanize it, but I still do worry about the black boxedness that you alluded to, Brian. Please, I'm not dissing it at all. I'm quite sure AI is coming, but let's try and harness AI as well as we can while keeping the human side of it. And which I exemplify in the last slide. This is not the sort of patient-centered care we want. We want both clinicians looking and working with the patient. So thank you one and all, and please stay safe.
Great. Willie, that was fantastic. Thank you very, very much indeed. And we're almost on time, which as Chairman is also worried. So thank you both very much for your excellent talks. And we'll discuss those very shortly. But before that, I'm pleased to introduce two further people to you who are going to give a talk. And the first is Andrea Brady, who is the mother of Jessica Brady, and she's going to speak to you now. So thank you very much, Andrea, for coming along, and we look forward to hearing what you're going to say.
Thank you. Thank you very much for inviting me. I hope you can hear me okay. We're all good. That's good. Thank you so much. My starting point is, and is always, Jessica, or Jess as we called her. Jess, I think Sopna's got actually a slide of Jess. I think she's got a photograph for me that I think she was going to show. Yeah, here's Jess. This was taken on Christmas Day 2019, and this was Jess's last Christmas because devastatingly she died 5 days before Christmas the following year. Some of you may recognise Jess from this photograph from our petition that's addressed to the Secretary of State for Health and Social Care West Streeting, which is Jess's Law, Improve the Awareness and Diagnosis of Cancer in Young Adults, which has secured more than 324,000 signatures. Before I talk about Jess's Law, I just wanted to tell you a little bit about Jess. Jess, it might sound a cliche to say this, but she was kind, truly kind, and caring and thoughtful, but she was also bright and funny and unassuming and full of integrity. She walked, she ran, she did aerobic exercise, she didn't smoke, and surprisingly, she didn't drink. In the summer of 2020, Jess was living with her boyfriend, and she was 26 years old. She was working as a radio frequency engineer, designing satellites for Airbus. She had a full and exciting future ahead of her, or so we all thought. In the June of 2020, Jess had moved from her family GP surgery to one that was more centrally located where she was then living. And it was at this time that she approached her GP because she was experiencing abdominal pain. And it was through a virtual appointment that she was diagnosed with a UTI infection. And she was prescribed antibiotics. So this was obviously in the absence of a physical examination and without providing a urine sample for testing. Although Jess's abdominal discomfort eased, very quickly her general health did not improve. And most noticeably, she was suffering from extreme fatigue, and she developed a persistent cough that was so aggravated that she had to speak in a whispered voice because she didn't want to further irritate her throat and chest. Over the next 5 months, Jess's general health declined noticeably. She suffered from intermittent fevers, noticeable weight loss, vomiting. Her lymph nodes were extremely enlarged. She developed a sensitivity to taste and smell, and she had previously had a really good appetite, and she found it very difficult to eat. From the June to the November, Jess contacted her GP surgery on 20 occasions, and on 3 of these occasions she was seen face to face. 4 different doctors consulted with Jess, but never her named GP. She was prescribed during this time 6 lots of antibiotics, steroids, inhalers, nasal sprays, and antacid tablets. She was finding it increasingly difficult to navigate her illness because she was feeling so poorly and because she was having to advocate for herself, and she felt like a problem patient at her surgery. And as a family, we were increasingly concerned about her, both her physical health and the impact it was taking on her mentally. There were a few pivotal points during Jess's illness, but one notable one was when her GP practice instructed her to go to A&E for a chest x-ray. And it was during this visit some bloods were taken, and she was found to have a raised D dimer. A scan at A&E showed she had an enlarged heart, and the following week she had heart monitoring, but no further action was taken. If we move forward then to early November, I was extremely worried about Jess by then, and I was permitted to go with her for a face-to-face appointment. And it was at this appointment that we requested Jess was referred to an ear, nose and throat specialist. That request was not granted. The evening of that appointment, I wrote a long letter to Jess's GP surgery expressing my grave concerns about her health, and we made the decision to pay for a private referral. So Jess visited ear, nose and throat specialist, and it was through this appointment a biopsy of her enlarged lymph nodes was taken. The following week, she was seen in outpatients, and she was told she had secondary cancer. She was immediately admitted to hospital, and the following day she was diagnosed with stage 4 adenocarcinoma, cancer of an unknown primary, and it was found that her cancer had spread to her liver, lungs, spine, bones, and lymph nodes, and it was thought that it had originated in her esophagus or stomach. Jess had to stay in hospital. She wasn't able to be treated in a hospice because her oxygen requirements were such she couldn't be catered for. And devastatingly, she died 3.5 weeks later on the 20th of December 2020. Admittedly, Jess's cancer had been sneaky, but it had been leaving vital clues. The problem was that at Jess's GP surgery, an unsubstantiated diagnosis of long COVID had been made, and this was in the absence of Jess ever having tested positively for COVID. Jess knew her body, and she knew her body was failing her, and she really was fighting 2 battles. On the one hand, coping with her increasingly debilitating symptoms, and the other hand, persuading anybody to listen to her. Like so many other parents who are devastated by the loss of their child, I would like to bring about positive change in Jess's name. And the proposal for Jess's Law is a simple one. I will read it to you. It is, if after 3 consultations, a patient's condition remains unresolved, or the symptoms are escalating, and or they have no substantiated diagnosis, the patient's case should be elevated for review and a new assessment made. And that is 3 strikes and we rethink. If Jess's law may sound like obvious, something that should happen anyway, but through our campaign, we have discovered or been introduced to countless accounts of patients, a lot of young patients who experienced something very similar to Jess, where they had visited their GP surgery in excess of 5-10 times. And often they are given an unsubstantiated diagnosis of something like stress, a pulled muscle, migraine, irritable bowel syndrome. The list is endless, really. So really our calls are to equip GPs to feel that they can rethink again, they can be curious, they should deviate from their initial diagnosis if things are not changing. And really, if the old training mantra for doctors, 3 strikes and you're in, has been lost over the years, I think the people that we've met and medical practitioners indisputably say that they would like it reinstated. Before closing, the mission of our charity, Jessica Brady Cedar Trust, I think something may have a slide just to show you what our charity looks like. Again, here it is. Our mission is really to support GPs to improve awareness and to improve earlier diagnosis. As we all know here, only 54% of cancers are diagnosed at stage 1 and 2. And as we've heard today from Willie and Brendan, it's absolutely imperative that cancer is caught early. And currently, we are working as a charity to fund a training programme. We're working with the Royal College of GPs to help improve earlier diagnosis and increase awareness. Thank you so much for listening.
Andrea Brady, thank you very, very much for sharing your story and telling us about Jessica. It's a very sad and moving story. So thank you very much, and we'll come back and have a chance to discuss that in a moment. So and now we have Pam. I can see you there, Pam Esler, shows you're a lay leader supporting patient involvement in the Shared Safety Action Plan, and we're very keen to hear what you have to say too, Pam. So over to you.
Thank you very much. And Sotner has very kindly agreed to sort of share my screen for me, and share my slides rather. And I'd like to start by just saying a big thank you to Andrea for sharing her personal story there with us. So much of what she described there sort of runs, so many of the themes run through what people have been talking about this morning. And it particularly relates to the area that I'm going to be talking about, which Professor Hamilton also touched upon, which is the Shared Safety Net Action Plan, or as we very sort of fondly call it, SNAP. So next slide, please. What is SNAP then? Well, we've heard this morning about people often turn up at their GP surgery with fairly generalized symptoms. And I was also struck by Andrea saying that Jess knew her body better than anybody else. And I think that's the same for all of us. We know something's not right. And eventually we reach the point where we go to the doctor. But what we talk about is sort of very generalized. It doesn't warrant any further investigation at that stage or whatever. So what do we do then? Too often, as members of the public, we're sort of sent away with, don't come back if it's not getting any better. And it's really difficult to understand then as a patient, what does it mean? if it doesn't get any better? How soon can I go back? Am I bothering everybody? Am I worrying unnecessarily? So the idea of the safety netting plans is to actually give patients some guidance as to how they can assess and monitor where they feel they are with their health and what steps to take next. So as you can see, it's a simple tool that's been developed to involve patients fully in safety netting conversations with their healthcare professionals. Just what Professor Hamilton was talking about, which was having that joint conversation there between patients and clinicians. And it's focused on people who turn up with very generalized symptoms such as fatigue, a bit of weight loss, perhaps sort of after a bereavement or whatever, things that are very non-specific. They could in time be a sign of cancer, but at that particular stage, they don't want any further investigation. And what SNAP does is actually guide patients and clinicians through their discussions and gives a summarized outcome, which is either in a paper form or can be sent by text or email. And the outcome is that patients have got a clear understanding of symptoms they need to monitor, and it starts off with a discussion about what the symptoms of worrying patients are, and from that you can pick out the ones that they really need to monitor, what to look out for, what timescales might be, and the circumstances under which they should go back to the practice again. Now, the development of this tool has taken quite some time, and it started out as a very simple body plan, which then progressed to the next one that you can see here, which was slightly more specific. But we do now have quite a sophisticated form that has potential to be integrated into System 1, the most commonly used GP IT platform there. Now, it might seem a very simplistic thing. Why on earth do you need to be supporting a conversation in there? Why is this needed? And for me, there are sort of 4 reasons why it's needed. First of all, the hard data, as people have mentioned, too many cancers diagnosed at stages 3 or 4. And no matter what we do to try and work within the community to increase uptake of diagnostic tests and so on, we're still not making the progress we want to make. And some of that might be that people are reluctant to go to the GP with generalized issues. We've heard talk this morning about patient and public feedback, everything from complaints through to anecdotal reporting, mass headlines and so on, saying I went to the doctor 3 or 4 times and nothing happened, or I was just told to come back if it didn't improve. The whole issue of safety netting is a problematic one, I think, in terms of delivering that effectively from a professional point of view, and also in terms of recording that. I do a little bit of work with NHS England about supporting GPs in their practice and so on. And very often when an issue arises, if you look back through the notes, there's scant reference there to safety netting, so you don't know whether it's happened or not. And there's certainly no clear recording there. So this would help both, the development of this tool would actually help both patients and clinicians there. And lastly, in the changing world that we live in terms of healthcare, it's a support in terms of improving that decision making between clinicians and patients, because shared decision making is now being promoted as the norm rather than the rather paternalistic approach to healthcare. And also it supports continuity of care, where patients and their families might be part of one great big practice where they never see the same person twice. So next slide, please. Thank you. So, how did engagement help to shape SNAP? Well, patient and public engagement was core in developing the very first paper-based tool that I spoke about, and later on in supporting its refinement. I think it's interesting to note that when a call went out just very generally for people who might be interested in supporting us around some of the patient engagement here, we had a relatively high uptake from a wide group of people, showing that this issue had actually sort of touched a large proportion of the population. And also those people stayed with us through 3 engagement sessions. They didn't lose interest. They really used their experience to make things better, just as Andrea has described that she is doing. And the engagement was as wide and diverse as we could want it, as I suggested, not only through the patient engagement, but also through the engagement that was done with GP practices, some of which were from an urban area where they might have a greater turnover of GPs and continuity was more important, and some from rural areas where there was perhaps a more focused individual relationship between the GP and the patient. Thank you. So, when in our engagement with patients, what did they tell us? They really welcomed the focus and clarity that this gave to the whole process of discussing their concerns with GPs and recording of the outcomes there. They liked the fact that they really appreciated the fact that having this process in place almost legitimised their ongoing contact with the surgery, because as part and parcel of the plan that they're giving, there are clear indicators in there of what to look out for in terms of worsening symptoms, new symptoms. They're given timescales for going back. They're given contact numbers. They're told to say that they are actually on the SNAP program, and they're even given a very simple patient diary to record their symptoms there. So they felt there was a real focus on what was worrying them. They highlighted to us the need to make sure that the tool was tailored to the needs of the patient. So I've said that the most prevalent, the format that is really going to be taken forward is based on an IT program, but it can be printed out for patients. They can be emailed it, they can have it sent by text, and there's also the chance of using that very simple body outline that we saw earlier on for people who might have language problems or cognitive issues. The role of carers was really highlighted in our discussions there, that very often people were worried about relatives who perhaps went for consultations, didn't really understand what was going on, didn't take everything in. I think research shows that we all recognise about 25% or remember 25% of what we're told, and carers, bearing in mind that there might be issues in terms of confidentiality, but they really welcomed the fact that they would have a record there that they could work through with their relative and the person they're caring for, to make sure that there was clear understanding and progress there. And the last thing that patients raised more than once was this discussion about being able to separate out chronic and acute symptoms. People who had long-term conditions felt that very often they went along with what they thought were new symptoms, only to be told, oh, well, it's due to your asthma. One lady felt very passionate about the fact that because she was going through the menopause, everything she mentioned was put down to the menopause, and she wasn't able to have that distinct conversation about this new, as she felt it, this new symptom there. And then when we engaged with clinicians, next slide, please. So again, there was welcome for the focus that this work gave to the consultation, particularly around the fact that in terms of not only the outcome for the patients, but actually within the records, there would be a clear summary of the safety netting, so that everything through from clinicians being actually professionally protected, as it were, by that, through to actually passing care on to other people. They did raise the issue of time, that the plan, the whole process for developing the plan needed to be sharp. You needed to be able to get through it in a 10-minute appointment, and that has helped adapt the format of it. And again, we go back to the electronic version there that was so important as the ongoing record. So where are we up to next? A funding bid, a fantastic group of people have worked on a funding bid to get funding naturally to take us forward so that we can actually test this model out with 6 practices across the north of England, taking into account the variation there. We've done a little bit of feasibility or checking out of the tool within one practice in our local area. One of my colleagues and myself acted as proxy patients and tried out the tool there. It was interesting to see the variation actually in terms of how GPs used it, but at the end point, both in terms of the engagement experience and also in terms of the outcome, there was similarity there, so that was good. But there's need to do fuller, larger scale testing, particularly around the public engagement, to make sure that this tool is actually appropriate for all the sections of community that find it difficult in actually sort of that interface within a clinical setting. And then the other thing for me is that in the different areas that I'm involved with, just as a layperson, there's been a lot of interest shown in the use of this approach in other areas. So one of the areas that was really highlighted to me was waiting list management. We've got people sitting on waiting lists for 12, 18 months now, either going back to their GP surgery too often to say, where am I going? Or actually sitting there while their condition worsens. And if we had a tool such as this, we'd be able to help in that process. So last slide, please. Although I'm here presenting this as a layperson this morning, I have to say huge thanks to not only the whole team who's developed this, but also to 3 researchers in particular. Doctors Hannah Hartley and Alice Dunning, who really developed this tool and did a fantastic job in terms of engaging with the public and clinicians. And then Dr. Lynn McVeigh, who's picked this up and is now looking to get funding to take this forward and embed the next stage of research process to help evaluate and hopefully eventually lead to the embedding of this tool and use of this tool across primary care. So thank you for listening.
It was a pleasure to listen. Thank you very much indeed, Pam. Now we come to that point in the afternoon when I can throw this meeting open for discussion. And I'm sure that there are lots of people who want to make comments or ask questions to our speakers. So who would like to make a contribution at this point? I've got too many screens to see. So please don't be coy. in coming forward with your questions. Do I see any questions? I'm fascinated by the POCUS, but point of care ultrasound. And I wrote something in the BMJ saying I thought it was hugely underutilized. I don't know if Brendan or Willie have got any views on the POCUS, which lets you see inside a patient.
Yeah, Richard, I can talk briefly about handheld ultrasound.
Yes, I should have said handheld ultrasound, yeah.
Yeah, it's been around for a long time. I mean, I say a long time, 20, maybe 25 years. I remember even doing it myself, stilling an obstetric ultrasound while I was working in Malawi to look at a liver to see if there was amoebic abscesses in the liver. So it's difficult to know how useful it is, because the honest truth is we GPs are not that experienced in it, and we, both in terms of placing the machine in exactly the right place and interpreting the image. Gross abnormalities, I think we can pick up. More subtle abnormalities we can't. And while I'm in favor of doing more testing, even if the testing is imperfect, this one's a fine dividing line. I would feel fairly uncomfortable if it came into general practice in an unsupervised way. I know the young medics, you and I share the next generation of doctors as children. They're waving them around in casualty like they're a third arm. But I'm just not sure in general practice they are quite safe enough.
Brendan, you seem to like that answer, Willie's. I myself think everybody's far too reticent, especially in this country, about POCUS. It seems to me that it's an obvious thing to use. Granted, it shouldn't be used in an uncontrolled way, but there should be more courses. GPs should be incentivized to go on them. There should be an essential skill taught at medical school. Oh, and yes, we should evaluate it as it's rolled out.
Yeah. You can persuade me, but there's still a lot of persuasion to be done, Richard. We GPs have a heck of a lot of things to learn and retain, and for every skill that you want to add to our panoply, there's one that doesn't get taught. And please, I'm just uncertain.
Yeah, I mean, I think perhaps in a larger practice there could be one partner who might train up in this thing. It's a bit like a dermatoscope. I mean, you look at it and you think, okay, dermatoscope should be fairly easy to use, but actually it's not. And it's not something you can just pick up and, you know, looking like an ophthalmoscope. But one of my colleagues went on a training course. He has a dermatoscope, and we use him as a, can you come and have a quick look at this? I'm not sure whether to refer or not. And, you know, it's really useful. So maybe in those controlled circumstances, but there are lots of hoops to do something safely, and so many courses on this, certifications on that, agreements on this, payment. You know, how do you cost in the extra work? So many questions about how you would implement something like that, Richard.
Richard, there's a question in the chat as well.
So there's a question here from Asaba. How does SNAP integrate with existing care protocols in healthcare? So I think this is a question for you, Pam Estlin.
Yes, and I'm afraid it will be a layperson's response, but it might be others like Rebecca who might want to come in here. You know, as I understand it, this tool is only useful, well, it should only be utilised in a situation where the GP has made that decision, and his decision will be based on his personal experience and all the protocols and everything, that actually at this moment in time, the patient does not require, their symptoms do not require any further investigation. So it's that initial decision-making point, I think. If there was, and interestingly, we tried out this tool with a number of scenarios, quite sort of loosely. And to begin with, the GPs were actually sort of wouldn't be using SNAP for any of the scenarios we looked at, because they knew we were looking at perhaps sort of cancer-based scenarios. They immediately send everybody off for a test and so on. But when we began to refine the scenarios a little bit more with some of the local GPs, yes, there were instances where actually the GP would use their judgment to say, at this moment in time, this person does not require any further investigation. And as I say, they will have nice guidance, protocols, and everything behind them informing that. But it's down to that critical decision there. And I heard talk earlier on about actually the effective use of resources too, which sounds a very cold way of dealing with people and their worries and their fears and so on. But not only can over-testing inappropriately actually use up resources, but actually it's often distressing for the patients too, and is unnecessary. But all decision-making has risk attached to it. So that's a layperson's interpretation. Rebecca might like to come in with something slightly more refined.
I've got much more to add to that, Pam. That was a really helpful explanation, other than to say when we developed this, we co-designed it with patients and staff. And what the GPs told us was that they do safety netting anyway. We know we've already heard about that today. What they didn't necessarily do is consistent safety netting of this type. So the safety netting varied quite considerably, and this just tightens it up a little bit. We also asked the GPs when would they do this, for which patient groups, because this has been a problem when we've gone for funding, in that the funders and reviewers have said, okay, well, tell us which patients you would do this for then, we need to know. And the GPs have pushed back against that and said, we just have a feeling where there's some uncertainty, there's some vague symptoms, that we would find this useful to use in that conversation with the patient. So vague symptoms is about as far as, of non-specific and vague symptoms is about as far as we've got in terms of the patient population that you would use this for. But in answer to your question, yes, it does seem to fit well with existing protocols. And where there are gaps in those, perhaps.
That's lovely. Thanks very much. Well, that's a very full answer to that question. I've just done a look for any other questions, and there are no hands up. But there is a question from Jenny in the chat. I don't know if you want to say your question. It says, is research into AI and diagnostics taking into account consideration of inequalities? I'm not sure which kind of consideration you had in mind there, Jenny. Do you want to be more specific in your question, or do you just want Brendan to answer it?
I just want to know if it's featuring, because it feels like quite early doors with this, and I'm conscious that in terms of the research that we do, we are moving towards a stronger focus on EDI, and that's late in the game. So I'm wondering with AI where that is currently.
Yes. Thank you for that. We're relatively early stage. I mean, the project is based between technology readiness levels 4 and 7, for those who are familiar with those. But so just prior to large scale socioeconomic evaluation, but exactly the point where EDI needs to be taken into account. And it was a core question that was asked to us by the funding panel, NIHR, unsurprisingly. And we've dealt with it in the following way. For a start, I mean, thinking about how bias and issues around inequalities may come in, you've got the algorithms, the learning, the way the tool operates, the way it's implemented, the interface, its usability, and the recommendations. So we've got a work task around really trying to unpick issues of representative bias and missingness within the Kent, Medway and Sussex data set that we're using to do the algorithm work. And we plan to create a framework for the representation of bias in that data, and then use that later on as a logical check in the decision model. So it will alert potential for bias because of poor data or gaps and things in underlying data sets. So you have a logical framework which the AI can think about EDI issues as it's making its recommendations. And the first two tasks, we are looking specifically with patients, and we're doing a comparison of what Genie collects versus what the GP collects in terms of information for accuracy and potential safety risks. But that's a mixed methods evaluation. We're also interviewing GPs and patients, and we're having a framework that addresses EDI issues. So both in the sites for the 11 practices we're using, but also the patients that they're asked to recruit for the study. So particular issues that cover the main EDI type things with patients. So we're working with our NIHR with practice to make sure that the patients coming in are challenging the system, and we can identify where there are particular issues really early on in the design. And it's already informed sort of discussions about, Willie mentioned the Genie, the figure. I mean, this is the current one they're using in the US, but they also have different ethnicities, different ages, different genders, to do that, and potentially ability to give patients a choice as to what avatar they would like and feel most comfortable with, and ask patients in the group how they feel about that, for example. And then following up, I mean, the idea is that it's not a robot, but it's actually a personal that's driven by an effective computing layer that you can also manipulate. You can control how fast it goes, so for language issues, but you can also address the approach. So Genie will say, would you like me to be very to the point and cut the chit chat, or carry on as I am? So if you find the chit chat a little bit annoying, you can tone it down. So it's giving patients control a bit of that interface and how it works. So they're all issues to think about. And then, of course, the very important issue of closing the loop. I mentioned learning health systems, but I think they're really important from a regulatory perspective. That we monitor performance in specific target groups of patients and see whether there are things that we need to do to adjust the system going forward. So yes, it's been quite an exercise of interest in that area. Thank you for raising that.
Thank you, Brendan. That's very interesting about tailoring the script to the person's preferences. Well, I'm working on decision support, decision aids, and that's one of the interesting challenges we have there. People of different literacy may have different requirements, different health literacy may have different requirements. So I would like to perhaps pick your brain on that later, Brendan, if I may.
Sure.
Well, not for the first time in my career. Any other questions coming out? I mean, there must be lots of questions to ask.
Emily's got one in the
subject.
Yeah.
Who do you see, Brendan?
Emily Ong has asked a question about dementia picking out cognitive impairment at an early stage. I think, and I really loved Willie's talk. I mean, he's just fantastic at wrapping out the different agendas here. But this whole issue about not a specific diagnosis, but general diagnosis, and how do you pick things up? And there are so many conditions. Dementia is another we haven't talked about, which are real dilemmas for GPs. Very challenging. And how would you support GPs in doing this? And you could imagine that there are certain ways perhaps that people speak that might actually raise the issue about, does this patient have dementia? You could incorporate at length an AI-driven assessment tool before the patient comes to GP. We're not scrabbling around and thinking, oh goodness, how do I find the time to do this test, and what the hell's in it anyway, and more subtle things. And there are some very subtle screening tools for dementia which aren't in use that I consider from a research point of view, that you could potentially spin out into this. So I think the AI as a digital assistant for GPs offers huge potential benefits for GPs and patients in a number of different diagnoses. I think this is just the start. of how we move forward with things.
Yes, it's hard not to imagine that in 20 years' time, AI won't be taking over a bigger role of primary care and thereby releasing clinicians for other tasks.
Well, talking to patients, I think, will be the first thing.
Okay.
I mean, it's just so squashed. It's not, yeah, I mean, we have, the typical patient that in my experience raises 3 or 4 different problems now in a consultation. So even if you push your consultation length out for 10 to 15 minutes, if you're waiting for a month to have the consultation, they come in with a big list and you just don't know where to start. It's a real challenge.
Yeah, Richard, for the second time, I'm going to disagree with you. I hope we'll keep talking to each other. I cannot honestly foresee a position where the face-to-face interview or telephone interview between the patient and the GP will be replaced. Now, it could be supplemented, it could be augmented. We already have patients looking at Dr. Google before they come in and see us. But there is something about the drug doctor that is real. Now, I have listened, and Andrea in particular, your experience is completely against what I'm saying. That clearly your daughter had a ghastly experience with multiple interventions with general practice. But if general practice is done well, there is something about the doctor-patient relationship that has value, that we can't measure, but it's real. And I see Brendan nodding. So if Brendan and I agree, it must be right. Can I change topic just slightly? I want to come back to the patient issue here. What is fascinating in the diagnostic arena, patients have very much been on the back foot, that in terms of decision making and choice. In the therapeutic arena, we've made big advances in offering patient choice between 2, 3, 4 different types of treatment for this or that, including non-treatment. In the diagnostic arena, the patient voice has largely been unheard. And in part, it's simply seen as the doctor's job. The doctor's job is to make the diagnosis, and then the discussion starts. But I'm not sure that is true. Certainly in the screening arena, it's not true. In the screening arena, patients are being involved. But I still think in the diagnostic arena, we are missing the patient's voice about whether diagnostic intervention should go on.
Yes, being an ex vivo maternal medicine specialist, of course, that doesn't apply because prenatal diagnosis is an area where you don't do the diagnosis without consultation. But Chris, I see you got your hand up.
Yeah, I was going to ask, what advice do you have for people at the early stages of AI or other predictive model development to make the transition into the electronic health record or clinical practice easier in the future?
I think both of us have worked with EHR integration. I mean, Willie, your trial, the Erica trial, your integration with things. Do you want to start with that, and I'll chip in?
Yeah, sure. I mean, I don't want to repeat myself from earlier too much, but I mean, the Erica trial uses a pretty unsophisticated tool. Brendan talked about logistic regression and talked about AI. These tools came from LR, so they're not going to be as swanky as the things that can be produced. But what they do is they capture one of the 2 reasons why cancer is missed in general practice. I'm going to make a broad generalization here. It could be because the doctor doesn't think of cancer as a possibility. And that any tool Brendan produces or I produce can get on top of that. The second one is there is a difficulty in doing the investigation, either because NICE doesn't say it's okay, or because the surgeon sends you a snotty letter if you send another rectal bleeder and it isn't cancer, and that is deemed to be a failed referral, which is not a failed referral, it's just a lucky patient. So we've still been left with the barriers to investigation, and that side of it is at least as big a patient safety aspect as the selection of patient for possible investigation. Brendan, is that a helpful enough preamble to? I'm going to throw the baton electronically back to you.
All right. I've pinning back onto electronic health record integration. Chris, are you talking about workflow or technical integration, or both?
A bit of both, really. I suppose I'm thinking of, at the moment, developing a model to, for instance, predict antibiotic effectiveness. But that's in the data analysis phase. What do you think you can do at this stage to make integration into the electronic health record in the future more straightforward? If that makes sense.
I think the biggest challenge at the moment, and I do think it actually will change, but it's going to be a bit of a struggle, is that the moment the electronic health record is the sort of central orchestrator of everything that happens in a consultation. It's there, it's open on the desk, it's got everything else plugged into it in some way. So you've got this kind of spider's web of technology, and often that now works in an incredibly clunky way. So I was listening to Pam's thing, and I was thinking, this is really good idea, but I just hope it doesn't end up working like the asthma control questionnaire, where you have to go, you get a thing saying the patient has to have their, as part of their asthma review, has to have their control questionnaire done, and you have to give them a personalized asthma plan on the same day at the same time and record them in the EHR. So you go out of the EHR, you follow a link, you go to a website, you go through or send the patient the questionnaire with them, you get a result back, you come back into it, you manually paste it into the field in the EHR, and then you click another link saying generate a asthma management plan. So you go to another website, generates an asthma management plan. It's sort of linked with the EHR, and if it's anything like South East London, it takes several minutes of kind of plunking backs and forwards to decide it's actually going to talk to it. Produces a Word document that you can then print to the patient or send to them and save into the EHR. And I can pretty much guarantee that halfway through that, the whole system will go blue screen anyway. It is a complete nightmare. So these ins and outs through EHR systems, through their application programming interfaces, are very poor. And the reason for that is because there are NIHR standards for this. The companies do their level best to drill down on the absolute minimum required to do that. So you can operate a simple algorithm and you can pop it up and you can produce a template and you can save that and you could trigger some action based on that. But that's all within the capability of the EHR. If you wanted to do something nicer, to make it look nicer, to do some design, to provide some recommendations on the basis of the algorithm and to automate that process, you can't do that because it's happening within the EHR, which is the problem that we had partly when we came to try and do our own interface. It was just, we needed to write back a set of SNOMED codes on symptoms, which was a key thing that we were trying to do, get better symptom coding. And we found that the application programming interface for TPP, if you tried to write a symptom back that wasn't in the list, the primary care list for SNOMED codes that were supported by TPP at that time, it would just truncate it and wouldn't write anything else back and wouldn't warn you that the message had been truncated through the API and there's no safety check on that. So that's a big clinical risk. You think you're writing something back and it isn't. So that was a real problem. So you have to kind of manually go over that. So the idea I was thinking around was, why can't we take more control of this before it gets to the EHR, work with patients perhaps? And then Stephen came along, and Stephen is kind of a bit of a man with a mission, and a little bit like the Brady's. His brother died of a unrecognized BRCA-related skin cancer because of a strong family history of BRCA cancers. No one thought that melanomas, or remembered that melanomas are actually a BRCA-related cancer. And no one thought about it, and then he had this skin lesion which was late diagnosed as a result of that. So he came to the conclusion that an AI could do a better job in this area than an unaided doctor. So he spent 10 years building this through various iterations. I think we're at the right kind of time for that, because the moment general practice is buckling under so much, and a lot of that is the extra stuff that's been layered on top of really primitive health record systems that make our lives harder rather than better, and spend more and more time fighting the IT systems and doing admin, and cannot include any of the nice design stuff that's potentially around. So either we have to have a new EHR systems, or we have to leave them on one side as a kind of legacy recording bit and build on top of them much better, much safer, and well validated and modern systems. That, I think that's a big area of development in the next couple of years. Response to that. So to answer your question in a long-winded way, it's difficult currently, but I think things will be changing, and it's projects like ours and others that will be pushing that with doing things. Does that make sense?
That's a very interesting topic. We got studies on maternity care records, and there's a patient history taking module, which doesn't talk at all to the patient maternity record, which itself doesn't talk to the prescribing system. It's a total and utter mess. And that's even before you come to the sorts of things you described with asthma. That's a horror story, Brendan.
Yeah. I mean, it's part. I mean, I read Aradazi's report on a quick skim read last week, and it's kind of there, but he doesn't overtly highlight. He talks about IT failings and lack of capital spend on IT, and the fact that budgets have been raided. But struggling with inefficient IT systems is such a key cause of poor productivity in the NHS, particularly in hospitals, I think, as well as in general practice.
So Rebecca Lawton's written a long response to all this, and I can see her on my screen. So rather than read it out to you, I'll ask her to read to you what she's written.
Yeah, it's just really about the limitations, Brendan. Completely agree of the systems that are in place, and the temptation then to build in, the possibility of linking in with other external systems. But then, as you described, that just makes the whole task and consultation so much more complex, doesn't it? So in the end, our GPs and practice nurses said, just keep it simple and in TPP rather than trying to do anything fancier, but that links out to external platforms. So I think that just spoke to one of your earlier points.
In TPP means in what?
One of the main EHR systems.
Oh, I see.
Yeah, system one. The what Stephen is very interested in the US, so they've gone out to market with concierge practices in Florida. So I said, what's a concierge practice? It's a practice where patients pay extra to have a VIP contact with the GP. So they've got about 40 early adopters now, where Jeannie, the chatbot, is the door to the practice for these very demanding patients in the US, and it's going really well, particularly because it allows the clinician and the patient to close the loop. Because you could have a consultation and you could say, well, I want to check in with you in a month's time to see how you're getting on with this, or safety netting. And you can ask Jeannie to do just that, check in with the patient, and all remotely from what's happening in the practice. So I think there's a convergence there potentially with these kind of tools.
Oh, interesting. Well, that's very, very interesting point. Has anybody else got their hand up? Let me just scroll across and see if there's any. Such an interesting topic. I can't believe they're not a plethora of interesting questions. Brendan, I didn't really understand that you described, if I understood correctly, described the AI system doing its thing on a large language model, and its output then being an input into a standard, statistical model. Did I get that right, or have I scrambled that in my brain?
Oh, when I was talking about the model we've done for lung cancer, which is a preprint, by the way, and is currently back out with a journal after review. Yeah, so when you create this rich neural network with the attention scores across each layers, you've got a very rich representation of a complex data set, and for each individual within that data set, it creates an embedding, which is not just the list of the data, but actually the data and its importance and its differentiation in contrast with other data in the data set. So when you feed these embeddings and the attention scores up, you have to do something with them statistically. You need an answer. It's equivalent of asking a question of a model. So the question we were asking was, what's the predicted performance of a bimodal thing, either cancer or not cancer? Therefore, logistic regression model is an appropriate model, but there are others you could use to do the same thing. It's that top layer is important, and I think
it wasn't the logistic regression model versus the it was the logistic regression model sort of superimposed on the other model to see.
Yeah, it's a part of it. Yes, the end stage. And we also compared it with just the logistic regression classifier, not on the embeddings, but on the 450 code group concept as a comparator. So it's effectively asking what's all the complex work of creating these embeddings with attention scores and things. What does that add to the work you've already done? Because it's a composite of the classifications, the dimension reduction, the 450 groups, and the approach to using the rich data, as well as using this particular model in it. I mean, it's quite interesting, and there's, I think, a lot of questions about how we can do this more efficiently, because you can put other kinds of models on top to do with that. I mean, Willie, I mean, you've done a lot of seminal work on health data analysis and cancer risk prediction. I don't know what your thoughts are on where that's going statistically in the future.
Yeah, it's an interesting statistically. I think your picture of the two ROC curves alongside each other told the exact story. That firstly, the traditional models, the logistic regression, and I hope we're not losing the audience here. That's 2 and 2 equals 4 form of statistics as logistic regression. It's pretty simple. Even I can understand it. It produces pretty good prediction. Where AI, and I've done it in other cancers, I haven't actually done it in lung, it produces slightly better figures. Now, you may think slightly better. I think your figures went from 88% to 92%, your area under the ROC curve. 4% doesn't sound much, but actually, once you start getting very close to 100%, 4% is real money. It really changes the number of false positives and false negatives. You can avoid doing unnecessary chest X-rays or avoid telling people they don't have cancer when they actually do. So 4% is worth having. The difficulty, as again we've alluded to, is the black box issue and the complexity of it. We have to make sure the complexity doesn't become so difficult that it's more difficult than doing a chest X-ray form. Sorry, that you're going to tell me, Brendan, that's not a fair comparison, but I think you know what I mean. Currently, I could write a chest X-ray form if I think the patient may have lung cancer. I don't want to have to add in things like Brendan's doing if I'm pretty flipping sure that it's worth doing a chest X-ray form. So we have to be careful not to chuck out the old that's working to bring in the new that might work better. We have to get the two alongside. Brendan, you're nodding. I'm sure there isn't a hate between us in our views of that. But let's keep both, which is why I said no to Richard saying having the robot instead of me in the morning surgery. You're not having it, Richard.
Well, one day I probably will when I'm an old man, even older than I am now. Rebecca asked about communication about false negatives. Funnily enough, I'm writing a piece for our news blog on the very issue of communicating probabilities to patients, and the icon method is supposed to be, according to the great Geigerenzer, supposed to be the best way to bring about that concept. But of course, the people with a high literacy numeracy will be able to understand it better than people without. But the best hope, I think, is currently is that I mean, when you get to my age, you have your fecal stool test, and that's very clear that you can't be reassured totally by the negative result.
Yeah. It's even happening at my age, Richard.
Yeah. Oh, well, long may it be negative. So I think that we are drawing to the end of the this. It's been for me a very rich discussion covering everything from the human side of where when healthcare is not safe to the statistical sides of how we can make it safer. And a walk down Lemmery Lane was reference to people like Lawrence Weed, of whom I used to be a disciple, and Balin too. I thought you brought up, Willie. So it's been a very intellectually rich and emotionally rich experience. I'd like to thank everybody for participating, all 91 that I think we had at the peak, and then our 4 speakers, one of whom's had to leave, but the 4 speakers who've contributed. And I would also like to thank my assistants, Pam and Sopna, without whom this would have been a dog's breakfast of a slideshow. So to you all, thank you very, very much indeed. Lovely to see old friends and new. And thank you for attending the meeting. Bye now.
Likewise. Thank you. Great pleasure.
Bye.